hold ended.
Hello, I am AARP Vice President Bill Walsh, and I want to welcome you to this important discussion about cost-saving changes to Medicare that may affect you and your loved ones. Before we begin, if you'd like to hear this telephone town hall in Spanish, press *0 on your telephone keypad now.
Si usted desea escuchar en español, presione asterisco y 0 en su teléfono ahora.
AARP, a non-profit, non-partisan membership organization, has been working to promote the health and well-being of older Americans for more than 60 years. And for much of that time, preserving and improving Medicare has been a chief focus for AARP. Today, there's important news to share. Thanks to landmark legislation passed last summer, Medicare beneficiaries will begin getting some relief from out-of-control prescription drug prices. Under the new law, more than 65 million Americans will see immediate benefits, such as free vaccines and caps on the cost of insulin. Longer term, they will also see lower costs for some of the highest-priced drugs on the market and a cap on their annual out-of-pocket spending for prescription drugs. AARP fought hard for this legislation, which takes an important and long overdue step toward corralling the skyrocketing cost of drugs for older Americans. Today, we'll hear from an impressive panel of experts on these important changes, including from the head of the Medicare program. We'll also get an update from Capitol Hill on legislation important to older Americans. If you've participated in one of our teletown halls in the past, you know this is similar to a radio talk show, and you have the opportunity to ask your questions live. For those of you joining us on the phone, if you'd like to ask a question, press *3 on your telephone keypad to be connected with an AARP staff member who will note your name and question and place you in the queue to ask that question live. If you're joining us on Facebook or YouTube, you can post your question in the comments. Hello, if you're just joining, I'm Bill Walsh with AARP, and I want to welcome you to this important discussion about changes to Medicare and how the end of the COVID-19 public health emergency in May will affect Medicare beneficiaries. We're talking with leading experts and taking your questions live. To ask your question, press *3 on your telephone keypad, and if you're joining on Facebook or YouTube, you can post your question in the comments section. Today, we're joined by two of the foremost authorities on Medicare and how the changes enacted last year will affect beneficiaries now and for generations to come. We'll also be joined by my AARP colleague, Tricia Sandiego, who will help facilitate your calls today. This event is being recorded, and you can access the recording at aarp.org/RX. Again, to ask your question, press *3 at any time on your telephone keypad to be connected with an AARP staff member. Or if you're joining via Facebook or YouTube, drop your question into the comments section. Now I'd like to welcome our guests. Meena Seshamani, MD, PhD, is the Director and Deputy Administrator of the Center for Medicare. Welcome back to the program, Doctor.
Thank you so much for having me. It's great to be here.
All right, we're delighted to have you back. Also joining me today is Leigh Purvis, a Senior Director at AARP and an expert on healthcare cost and access. Welcome back, Leigh.
Thank you so much for having me.
All right. Thanks for being here. And just a reminder to our many listeners to ask your question. Please press *3 on your telephone keypad at any time or drop it in the comments section on Facebook or YouTube. Let's get started. Dr. Seshamani, we will see some of the biggest changes to Medicare in years as a result of landmark legislation that sought to contain the cost of prescription drugs. Can you give us the highlights of those changes and what they'll mean for consumers?
Absolutely, and it is a very exciting time where we really are able to deliver significant financial relief to millions of people on Medicare. So to start, Bill, you had mentioned starting January 1st, recommended vaccines are available at no cost to people with Medicare. So shingles vaccine, whooping cough vaccine, they're available without any out-of-pocket cost. Also starting January 1st, a cap on insulin payments. So people will not have to pay more than $35 for a month's supply of each covered insulin that they get through their prescription drug plan. And again, that is hugely important for people to be able to access this life-saving treatment. Now, the insulins that are provided through traditional pumps, that $35 copay cap will apply starting July 1st. And there are a variety of other provisions as well that really will bring real financial relief to people with Medicare. For example, starting in 2024, there won't be any out-of-pocket cost for people with Medicare once they hit the catastrophic phase of their drug benefit. We're also extending supports, financial supports for low-income individuals up to 150% of the poverty level, also starting in 2024. And then ultimately there will be a $2,000 out-of-pocket cap limit, meaning that people with Medicare prescription drug coverage will never have to pay more than $2,000 in a calendar year, and that will start in 2025.
Very good. And I understand under this legislation, the Medicare program can negotiate directly with drug companies to drive down the cost. Is that right?
Absolutely. And that will start, the process for that will start this year. So this fall, we will announce the first 10 drugs, high-cost drugs, to be negotiated so that we can make sure that we're keeping prices lower for people who really need these oftentimes life-saving treatments.
Well, let's talk about that a lot. I mean, people have seen runaway price increases for years. When will families start to see these lower drug prices, and why will it take some years for a few of these benefits to kick in?
Yeah, well, as we talked about, Bill, some of these areas of financial relief have already gone into place, like the insulin copay cap, like the free vaccines. It was really important to deliver right away because we know how much not only people with Medicare, but their families, their communities who support them have been struggling with these high costs. You know, moving to the drug negotiation, we'll announce the first 10 drugs this fall, and then we engage in that negotiation process with drug manufacturers so that by next year fall, we will have an agreed upon price, and that then goes into the prescription drug program to go into effect in 2026. And one other important aspect of the new drug law is accountability for rising prescription drug costs. So the drug law holds drug companies accountable when the prices of their drugs rises faster than inflation. And that has already started in January for Part B and October for Part D. But that is another way that the new drug law seeks to tamp down on rising prescription drug prices.
Now, I know a lot of our listeners are wondering, is my drug going to be on the list? I think I heard you say the first 10 drugs will be identified by this fall. Do we have a sense yet which types of drugs might be included?
Not yet. So what the legislation says is that we have to look at the top 50 drugs in total spend, and then there are a variety of factors that are considered. For example, drugs from small biotech companies will be excluded. Drugs for a rare disease will be excluded. Plasma and blood-derived products will be excluded. And so following the law, the language in the law, then from there, we take out those exclusions, and then the Secretary selects the first 10 drugs from that are the top spend.
Right. And just to be clear for our listeners, the limit isn't on 10 for all time. It grows over time. Is that correct?
That's right. So it starts at 10 this year, and then it goes up to 15, and then it goes up to 20. And that is per year. So 10 the first year, then 15, then 20. So, and it starts with Part D, but then it does start to include Part B, as in boy, in future years as well.
Very good. All right. Well, let's go to our lines. I know our listeners have lots of questions on this topic. And as a reminder to our listeners, press star 3 at any time on your telephone keypad to be connected with an AARP staff member to share your question. And if you'd like to listen to this program in Spanish, press star 0 on your telephone keypad now.
Si usted desea escuchar en español, presione asterisco y 0 en su teléfono ahora.
And one other note before we go to lines, if you're looking for individual Medicare assistance, please visit shiphelp.org online or call a toll-free number, and that number is 877-839-2675, and you'll be connected with a Medicare counselor in your state. That number again is 877-839-2675. All right, now I'd like to bring in my AARP colleague, Tricia San Diego, to help facilitate your calls today. Welcome, Tricia.
Thanks, Bill. I'm happy to be here for this important conversation.
All right, let's take our first question.
Bill, we're going to go with Ron from California.
Hey, Ron, welcome to our program. Go ahead with your question.
Yeah, they this new law to lower the prescriptive drugs is not going to involve apparently drugs that help with cancer or what have you, and which is really in the moon. Also, these drugs that are just ridiculously expensive. And then, on top of this, to add insult to injury, the the drug companies are not even happy with this reduction in price. They think it's outrageous, I guess.
Yeah,
They want to fight it. They want to fight this lousy, small lessening of the price. What's going on here? How greedy can they be?
Yeah. Good points, Ron. Well, let me ask Dr. Seshamani to address which types of drugs and whether cancer drugs will be subject to negotiation.
Yes, the legislation does not have any exclusion for cancer drugs. So cancer drugs could be part of the negotiation, along with many other types of drugs. One important point I mentioned, in 2024, when people hit the catastrophic phase of their drug benefit, they will be protected from paying anything more out of pocket. That is particularly important for people with cancer, because a lot of people with cancer, as you know, have higher drug costs. And so being able to protect people from having to just continue to pay out of pocket will be extremely important, especially for people with cancer.
That's a great point. Thanks for that, Doctor. Tricia, let's go back to the lines. Who do we have up next?
We're going to go with Roxana in California.
Hey, Roxana, welcome to our program. Go ahead with your question. Hi, Roxana. Hi, Roxana. Go ahead with your question.
My name is Rosina. Did you say Roxanne?
I did. I'm sorry. I got your name wrong. I apologize for that. Go ahead with your question.
Okay. I wanted to know, I think I heard that the shingle shot is going to be available with Medicare, that no out-of-pocket expense. And I wanted to know, what about the tetanus shot? My doctor had wanted me to get a shingle shot and a tetanus shot last year, and it cost so much money I didn't do it.
Yeah. All right. Well, let's ask the head of Medicare about that. Dr. Seshamani, can you address that?
Yes, that's a great question. Basically, any adult vaccine that is recommended by this organization called ACIP, all of those recommended vaccines are available without any cost to people with Medicare.
That's great news. All right, Tricia, let's go back to our lines. Who do we have up next?
Let's go with Lydia in New Mexico.
Hey, Lydia, welcome to our program. Go ahead with your question.
Thank you for taking my question. And it is, does Medicare cover home health aides and or caregivers, home caregivers?
Okay. Dr. Seshamani?
Yeah, thank you for that question. So in the Medicare law, there are various provider types that are listed who can bill Medicare. We have a home health payment system, in fact, for home health. So that, addresses a lot of the payments around home health. To your question about caregivers, and particularly family caregivers, this is an area that is of particular importance for me as someone who, has taken care of patients, until very recently, and I know how important it is to have that holistic support for people. And we're doing a lot in the Medicare program to really provide additional support in the community to be able to take better care of for people with Medicare. And I'd be happy to talk more about that also if you all would like.
Yeah, and Lydia, just so you know, we're going to address that a little bit later on in the program because that's something AARP very much supports as well. There are more than 50 million family caregivers in this country, and boy, wouldn't it be great if the Medicare program provided some assistance to them. For now, though, let's go back to our lines. Tricia, who do we have up next?
Bill, I think we're going to turn to YouTube, and we have a question from Lloyd. The question is, do I need to have Medicare Part C and or Part D to get these new changes?
Doctor, do you want to address that?
Yes. So the changes that we're talking about with the new drug law do apply to Medicare Part D as in dog, which is the prescription drug benefit, or for Part B as in boy, when there are drugs that are provided, for example, through a physician office. So in order to get the free vaccines, including tetanus, whooping cough, shingles, the copay cap on insulin, you do have to have Medicare Part D or Medicare Part B.
Now, I understand that Medicare is offering a special enrollment period. Is that correct?
Yes, we have several special enrollment periods for different circumstances. And in fact, to really try to improve access to affordable health care, we recently issued a regulation to, in fact, expand the various situations in which people can be eligible for a special enrollment period. So if you have, extenuating life circumstances, it is definitely worth contacting us at 1-800-MEDICARE to see if a special enrollment period could apply for you. Okay,
very good. And just a reminder to our listeners, they can also get a Medicare counselor in their own state at 877-839-2675. Tricia, who do we have up next?
We're going to go with Janet in Illinois next.
Hey, Janet, welcome to our program. Go ahead with your question.
Yes, thank you for the opportunity. Very nice conversation. The doctor already answered one question about the tetanus. I would like to get a tetanus shot. But then she also said something about an organization called ACEP, and I would like to know what those initials stand for. And I also want to know if the COVID booster will be covered, because I read something about it not being covered after May.
Good questions, Janet. Dr. Seshamani?
Those are great questions. So ACIP stands for the Advisory Committee on Immunization Practices. And that is a committee that provides recommendations on vaccines and other, related preventive therapies. So basically what the new drug law does is says that those vaccines that are recommended for adults by this organization should be available without any cost to the person with Medicare. Your second question, which is another very good question about COVID vaccines, I'm very glad that you asked. COVID vaccines will continue to be available for people with Medicare with no cost out of pocket, thanks to both the Affordable Care Act and the CARES Act more recently. So the access to the COVID vaccines, not having payment out of pocket does not change.
Okay, very good. And as a reminder to our listeners, if you'd like to ask a question, press *3 in your telephone keypad at any time. Or if you're joining on Facebook or YouTube, go ahead and drop your question into the comment section. Tricia, who do we have up next?
We're going to go with Diane in Illinois.
Hey, Diane, welcome to the program. What is your question? Hi, Diane, welcome. Do you have a question?
Hello, my question is, are the new laws going to cover the insulin caps with the long-term insulin injections such as Tresiba or Lantus or any of the other long-term insulin, or is it just the Humulin N and Humulin R shots?
Yeah, doctor, maybe you can talk a little bit about the insulin benefit. I know there's some nuances involved with it.
Absolutely. So basically, if you are getting your insulin through your Medicare prescription drug plan, for a month's supply of each insulin you take, you will not pay more than $35 a month. So if your plan covers, you mentioned Lantus or Humalog, if you are getting those through your drug plan now, then those will be covered where you don't have to pay more than $35 for a month's supply.
Okay. Let's take one more question in this segment. Tricia?
We're going to go with June.
Hey, June, welcome to our program. Go ahead with your question.
I was wondering, does the Medicare still cover hospitalization for people that's had COVID?
Doctor?
Yes, hospitalizations are covered, are paid for under the Medicare program. So nothing changes there.
Okay. And I believe as to the question around insulin, I believe one of the insulin benefits kicks in this summer. Is that right?
That's correct. So if you get your insulin through a traditional pump, the $35 copay cap starts July 1st.
Okay, very good.
But the vast majority of insulin are the types of insulin that you pick up from the pharmacy.
Okay, and that price is capped at $35 per month.
Correct. Now.
Fantastic. Well, thank you for those questions. We're going to take more of your questions soon. And remember, if you'd like to ask a question to Medicare Director Dr. Meena Seshamani or AARP's prescription drug expert Leigh Purvis, please press *3 on your telephone keypad. Let me ask a few questions to our experts. Leigh, efforts to allow Medicare to negotiate drug prices have been going on for decades. Why is it so important, and why did it take so long?
Yeah, thanks, Bill. I've been with AARP for over 18 years, and AARP has been advocating for Medicare negotiation for even longer. Our perspective is that it makes absolutely no sense that the Medicare program and its more than 60 million beneficiaries were stuck paying prescription drug prices that were largely based on what the market will bear. When Medicare's prescription drug benefit, or Part D, was created nearly 2 decades ago, the bill explicitly prohibited Medicare from negotiating with drug companies. Part D plans were able to negotiate on behalf of their enrollees, so there was some negotiating taking place. But even the biggest prescription drug plans simply do not have the same negotiating clout as Medicare on behalf of everyone in the program. And that's why AARP has been pushing so hard for Medicare negotiations. Medicare is going to have an incredible amount of power at the bargaining table, which will lead to a much better deal for Medicare beneficiaries and the taxpayers who help fund the program. And as far as why it took so long, I think it's safe to say that drug companies were not particularly fond of the idea of allowing Medicare to negotiate drug prices. And in fact, they've actually been blamed for the original prohibition on allowing Medicare Part D to negotiate. And they did everything they could to make sure it never happened.
And I'm sure they'll do everything they can to unravel it if that's possible. But we'll be standing guard to make sure that doesn't happen. Now, Leigh, don't private insurers and the Veterans Administration already negotiate with drug makers? Why would that be any different?
Yeah, that's a great question. And the short answer is it's really not. Private payers and the Veterans Administration have been negotiating with drug companies for decades and have been able to drive down drug prices for the people that they cover. But as I just mentioned, for a very long time, the Medicare program could not do the same thing. So really the big news here is that we're finally giving Medicare that ability to negotiate, and we are giving it a lot of power at the bargaining table, again, because it's going to be negotiating on behalf of tens of millions of beneficiaries. And given that Medicare is one of the most important sources of healthcare coverage in this country and the largest public payer for prescription drugs, this change was really overdue.
Okay, thanks so much for that, Leigh. And Dr. Seshamani, can drug makers refuse to negotiate with Medicare?
Thanks for that question. If a manufacturer does not provide certain information during the negotiation process or refuses to negotiate drug prices with Medicare, the law subjects the manufacturer to an excise tax. And this tax starts at 65% of Medicare sales and may escalate to 95%.
Now, who will monitor and enforce penalties when the drug companies raise their prices above the rate of inflation?
All of the penalties, all of the taxes, et cetera, that are in the legislation are monitored and enforced by HHS. So in this example, for the inflation rebate, so this is where if drug companies raise prices of certain drugs faster than inflation, they're subject to this rebate that they have to pay that money back, the differential. If they don't comply with that, there are civil monetary penalties in an amount that's equal to at least 125% of the rebate amount.
Okay, very good. And thanks to both of our experts. We'll get to more questions shortly. But let's get a quick update from Capitol Hill. My AARP colleague Megan O'Reilly, a vice president here at AARP, is here to share how AARP is fighting to strengthen Medicare and make prescription drugs more affordable. Welcome, Megan.
Happy to be here, Bill.
So today we're discussing, new improvements to Medicare, which must be thrilling to hear because, as you heard Leigh say, the AARP's been fighting for these changes for decades, really.
Absolutely. These changes will be making it easier for older Americans to stay healthy and will save Medicare beneficiaries and taxpayers billions of dollars. As we've talked about, AARP has been fighting for years to lower drug prices and other improvement, and it is a huge victory to finally see these changes enacted into law.
Now, of course, drug prices are only a piece of medical treatment. Why are the drug prices so important?
One of the things that we hear most from AARP members is their frustration and desperation that comes from trying to afford skyrocketing prices of prescription drugs. We know the most common reason that an older adult skips medication or rations their medication is because they simply can't afford it. Letting Medicare negotiate lower drug prices is a common sense solution, as is the new law that caps the cost of Medicare-covered insulin at $35 a month and eliminates out-of-pocket costs for most recommended vaccines under Medicare, such as shingles. This puts money back into seniors' pockets at the same time they're struggling to afford the rising cost of medicine and other basic needs.
All right. What are some of the other health improvements that AARP is fighting for?
We've talked about it today. We're fighting to help family caregivers, and we're also working to provide seniors with greater access to home care and more nursing home protections. In addition, we're also fighting for broader Medicare coverage for dental, vision, and hearing care. And for years, we've advocated for more affordable hearing aids, and as a result, lower-cost hearing aids are now available over the counter for those with low or moderate hearing loss. We're also fighting to allow greater use of telehealth, working to solve food insecurity, advocating for better mental health coverage, and fighting to expand access to affordable health care.
Okay, thanks very much, Megan. Now, before I let you go, Medicare and Social Security are once again in the news as Congress looks for ways to cut federal spending and reduce the deficit. What's AARP saying to Congress?
We're saying no way. It is outrageous to suggest Medicare cuts to Medicare and Social Security. We expect Congress to protect the benefits we have worked so hard for, and we're encouraged to hear a commitment to protecting Medicare and Social Security echoes from leaders in both parties, including President Biden, former President Trump, Speaker McCarthy, Leader Schumer, and Jeffries, and others. These programs are critically important to older Americans. Our members need to keep raising our voices and saying no.
All right. Thank you, Megan. Now, if listeners want to stay on top of AARP's advocacy news, how can they find out the latest?
We encourage everyone to go online to AARP.org get involved and sign up for the AARP Advocate. This is a free monthly e-newsletter, and you'll also receive email alerts and the latest advocacy news. Again, that's aarp.org/get involved. It's an easy way to make a big difference.
All right. Thanks so much, Megan, for that update today.
Thank you.
All right, now it's time to address more of your questions with Medicare Director Dr. Meena Seshamani and AARP prescription drug expert Leigh Purvis. Please press star 3 at any time on your telephone keypad to be connected with AARP staff and get in the queue to ask your question live. Let's go back to the lines. Tricia.
Bill, we're going to go to Lucy in Minnesota.
Hey, Lucy, welcome to our program. What's your question?
The rapid at-home COVID tests have become an important part of being safe for me and lots of people. And as I understand it, whereas it's been pretty easy to get free rapid at-home tests now from various government organizations, and also because people on Medicare under the COVID emergency could get 8 free tests a month, that's all going to end in May. And I'm wondering if there is, and those over-the-counter tests get very expensive if you have to buy them off the shelf in the drugstore, but they're not a prescription medication. I'm wondering, is there anything within Medicare that's going to shield Medicare recipients from at least part of the cost of those rapid at-home tests? Because, you know, my family, what we do, if we're going to get together, we test that morning, all of us. That uses up a lot of rapid tests.
Right. Lucy, thanks so much for that question. Dr. Seshamani, do you have an answer for Lucy and others who might be wondering?
Yeah, thank you for that question, Lucy. So as you mentioned, Lucy, during the public health emergency, Medicare has been paying for up to 8 over-the-counter COVID tests per month as part of what we call a demonstration, but that is tied to the public health emergency. So when the public health emergency ends, then that Medicare payment without out-of-pocket cost to the person with Medicare will also end. There will still be access to free COVID-19 over-the-counter tests through the U.S. Postal Service, as you have hopefully gotten tests through that avenue as well before. And we do have various distributions of COVID tests as well with many of our healthcare partners.
Okay, thanks for that. Tricia, who do we have up next?
We're going to turn to YouTube again, and we have a question from Beth, who just asked for clarification. Each time you say Medicare covers something, does that also include Medicare Advantage, Part C, or only traditional Medicare?
Doctor?
That's a great question. So Medicare Advantage covers what traditional Medicare Part A and B covers. So the things that we are talking about today for Part B, as in boy, applies for Medicare Advantage as well. And then Part D, which is the prescription drug benefit, is separate.
Okay. Tricia, who is our next caller?
Let's go to Texas. Robert from Texas.
Hey, Robert, welcome to the program. Go ahead with your question.
Yes, sir. I'm currently using the VA for most of my medical situations. I'm wondering how Medicare can come in when VA refuses to help.
Doctor, can you help with that? That's a good question.
Yeah, and I think this is an example where sometimes things are, case dependent, and so I would encourage you to call us at 1-800-MEDICARE, and we can look into your situation further.
Okay. Tricia, who do we have up next?
We're going to go to Joy in New York.
Hey, Joy, welcome to the program. What's your question?
Hi. So I know that some of this was already discussed as far as the vaccinations. So I was aware of the January 1st availability of being able to get tetanus and or diphtheria. So I went to my doctor's office and had the shot last month. So the question is, did it have to have been done at a pharmacy, or is it also covered at a doctor's office? And if it's not covered at a doctor's office, is there something that I can do to reverse or make it so that I don't have to pay for it?
I wonder if Leigh Purvis has an answer to that. Leigh, do you?
Yeah, that's kind of one of those questions that falls into the gray area with vaccines because there are two parts of Medicare that cover them. One is Medicare Part B as in boy, and that would be the doctor-administered types of vaccines when they're administered in office. And the other is Part D as in dog, to your point, that would be administered at a pharmacy. Again, the change that went into effect in January is related to whether or not it is an ACIP-recommended vaccine. So if your doctor made the recommendation that the vaccine was recommended for you and you received it in a pharmacy, that would be covered under this new improvement. Because it was administered in a doctor's office, that does fall into a gray area. So I can't say for sure exactly how Medicare is going to handle that, but my guess is that it would be covered under Medicare Part B as in boy.
Dr. Seshamani, do you have any clarification on that, or is that the best answer?
Yeah, I mean, there are certain vaccines that are covered in Part B as in boys. So in part, it depends on the vaccine as well. So I think this is an area where it is good to ask as well. But as Leigh said, for Part D vaccines, which is the vast majority, if they are recommended by ACIP, then they are available at no out-of-pocket cost.
Okay. Thanks very much. Tricia, let's go back to the lines. Who do we have up next?
We are going to go to Ronald in Texas.
All right. Hey, Ronald. Welcome to our program. Go ahead with your question.
Yes, two parts. I would like to know the best source to help me guide through this Medicare as I prepare to enroll in Medicare. I'll be doing that within the next 14 months. And I hear so many problems seem to exist when people are trying to enroll in Medicare. And my second part is prescription drugs involving those who have to take pills for their type 2 diabetes. I have to pay $300 a month for a 30-day supply, and that's with insurance. That's with private insurance. So, I mean, this new government involvement, is it going to help with that?
Okay, well, let's get both those questions answered. Leigh, let me turn to you first. Ronald was asking about sources as he considers enrolling in Medicare. I know AARP has a tool that helps people think through those questions.
We absolutely do, and it is incredibly comprehensive, so I hope that you can find all of the answers you need there. If you go to aarp.org/health/Medicare QA that will give you access to all of the information that AARP has pulled together in an effort to help our members understand what is a very complex health coverage program. So hopefully you can go there. But there are also a lot of resources available from the government. If you go to Medicare.gov, there is a whole lot of information that is available directly from CMS that can help you sort through your information. And they also have a great deal of good resources in the sense that you can actually ask it a question, and it will direct you to the answer that's specific to what you're asking. So I think there's a lot out there for you, and hopefully you'll be able to get all of your questions answered.
All right. Well, let me just repeat that resource that Leigh mentioned. That's aarp.org/health/Medicare QA tool. That's a guide to help pose questions to you and guide you through that what can often be a confusing first experience registering for the program. I'll also mention that the so-called SHIP programs around the country have free resources you can get on the phone and talk to somebody. Let me give you that number. It's 877-839-2675, 877-839-2675 to talk to a SHIP counselor in your state. And Ronald also asked about pills that he takes for his diabetes. Dr. Seshamani, will these be covered under the insulin benefit?
That's a great question. So the insulin copay cap is specifically for insulin, and there are other provisions that are going to be coming into effect that will help with drug costs across the board. So, for example, in 2024, for when you have really high, when you have high drug expenditures, then there is a cap that when you enter the catastrophic phase of your drug benefit, you don't have to pay anything more out of pocket. And then starting in 2025, you won't have to pay more than $2,000 a year. And that's for any drug, all put together under the Part D prescription drug plan. So that hopefully gives a little bit more information of where else. In the new drug law, it will address drug prices and costs beyond just insulin and vaccines.
Okay, very good. Leigh, let me ask you, let's dig into this insulin benefit for a moment here. The $35 per month insulin benefit kicked in January 1st, as you both said, but there's still been some confusion about how beneficiaries can get access to it. Can you talk about what's covered, what people should do if they've been charged more than $35, and who to talk to if they need help?
Yeah, that's a really important question because we want to make sure everyone is able to access this really important new benefit. The short answer is that everyone who is enrolled in a Medicare prescription drug plan should now be able to get their insulin for $35 per month. If your insulin is covered by your plan, you should receive that cost sharing. Now, if you're paying more than that, there are a few steps you should take. First of all, you should make sure that your plan actually covers your insulin. You can check your Medicare prescription drug plan's website, and it'll allow you to download the plan's list of drugs that it covers, and that will help you figure out whether your specific insulin is covered. Or you can also contact your plan directly. If you find out that your plan does cover your insulin and you paid more than $35 for it in early 2023, your plan has to reimburse you within 30 calendar days for any amount that you paid above that $35 limit. And your plan can help you figure out how to get reimbursed. Now, if you find out that you're in a plan that does not cover your insulin, you're actually eligible for a special enrollment period for the rest of 2023 that will allow you to enroll in a new prescription drug plan that does cover your insulin. Now, I know that was a lot, so if you need help with any of these steps, you can get in touch, as Bill mentioned, with your local state health insurance assistance program, or SHIP, and they can provide personalized assistance for Medicare beneficiaries. As you've heard, they're online at shiphealth.org, or you can call them toll-free at 1-877-839-2675. And of course, you can also find a lot of help information at aarp.org/rx.
All right, Leigh, thanks so much. And I'll just reiterate that aarp.org/rx page. We have a lot of information there about the new insulin benefit as well as the other benefits of the new law. Dr. Seshamani, let me turn back to you. The COVID-19 public health emergency is scheduled to end on May 11th. Why is the administration proposing to end the public health emergency when we're still seeing about 1,000 deaths a day, and 90% of those are among people 50 and older?
Thank you for that question, Bill. While COVID-19 is not over, because of the Biden administration's whole of government management response since day one, we are in a position where we can effectively lift the PHE and this national emergency. How have we come here? In the last 2 years, the Biden administration has effectively implemented the largest adult vaccination program in U.S. history. And we're at a different phase of the response to COVID-19 because we have the tools, vaccines, testing, and treatments to manage the virus. We're getting through this winter without a major surge, and hospitals, have not been overwhelmed as in previous years. And we've made a lot of progress in our fight against COVID so that it no longer controls our lives because of this approach. Serious illness is down, daily cases are down, and hospitalizations are down. And we make decisions based on the best science, data, and how we can continue protecting the American people with every tool at our disposal. And we know that there will be a lot to explain about the process, as evidenced by some of the great questions from the listeners today. Our commitment really is to a smooth transition, and we've been working to plan to end the emergency responsibly and to protect the health and well-being of the American people in doing so.
Okay, now when that emergency does end, what out-of-pocket costs will Medicare beneficiaries be responsible for?
Thanks for that question. And again, thanks to listeners who raised some of this earlier in our program as well. So, we got some questions about COVID-19 vaccines. So just to emphasize, nearly all Americans will pay nothing out of pocket for the COVID-19 vaccine after the public health emergency. Thanks to the Affordable Care Act and thanks to the CARES Act, vaccines are a preventive health service. And for Medicare in particular, vaccines will be covered at COVID-19 vaccines will be covered at no out-of-pocket cost to people with Medicare. For other services like antivirals, recent legislation also made those antivirals something that can be covered in Part D prescription drug plans. And so whatever coverage people have now, that coverage will not change when the public health emergency ends. Someone on our program had also raised the COVID-19 test. So access to free over-the-counter COVID-19 tests through the U.S. Postal Service will not change. There will continue to be, where there's distribution of COVID tests through various community partners. But the Medicare paying for 8 over-the-counter COVID tests per calendar month at the pharmacy, that will end at the end of the public health emergency. And I think at a higher level, out-of-pocket expenses for certain treatments may change just depending on drug benefit coverage. And we are exploring every option to reduce financial barriers to COVID-19 vaccines and treatments. And it's important for people to contact us at 1-800-MEDICARE or contact their prescription drug plan to make sure that they have the latest information.
Okay, very good. Thank you, Doctor. Leigh, Dr. Seshamani talked about the $2,000 out-of-pocket limit under Medicare Part D that will start in 2025. Can you talk a little bit about this? Why is it important? How many people will it help? And how is it going to work?
Yeah, I really cannot overstate the importance of this new protection for people in Medicare prescription drug plans. There previously was no limit on how much a person in a Medicare Part D plan could have to pay in a given year. And we know that over 1 million of them spent more than that $2,000 amount. In fact, there are some people who are paying over $10,000 per year, which is completely unaffordable for pretty much anyone, but even more so for people who are living on fixed incomes. So the other thing to keep in mind here is this $2,000 hard cap is actually just the second step. And you've heard mention of how next year there's going to be, people will no longer have to spend any money once they reach catastrophic coverage in their prescription drug coverage. Before that, you had to spend 5% of your prescription drug costs while you were in that phase of the benefit with no limit, which is how you heard about people with those incredibly high costs. And then the following year is when that new $2,000 out-of-pocket comes into play, which will be even lower than what people are spending in 2024. So it's a really important change that will help reduce the amount that some people on very expensive drugs have been paying that have really put them into those tough situations where they've had to decide between paying for the prescription drugs that they need and paying for other important things like their food or their rent, which is a decision that AARP has always said is not a choice anyone should have to make.
Yeah, the $2,000 out-of-pocket limit sounds like a real source of protection for people on Medicare. That is a really important piece of this new law. Let's go back to the phone lines and take a few more questions from our listeners. And as a reminder, if you've got a question, press star 3 at any time on your telephone keypad to get into the queue to ask that question live. Tricia, who do we have up next?
Next, we're going to go to Karen in Michigan.
Hey, Karen, welcome to our program. Go ahead with your question.
Thank you. Thanks for the great information. First of all, on the COVID vaccines, I'm very excited that they're going to continue to be covered. Will there be any limit on the frequency? Can it still be a booster every 6 months, or will coverage depend on some other time guideline?
Dr. Seshamani?
Thank you for that question. We continue to work with our colleagues in the CDC and in the FDA on what the recommendations are for how frequently COVID boosters should be provided. So we'll continue to work with them on that.
Okay. And is it your expectation, Doctor, that coverage of those vaccines will continue? I know you said they would continue after the public health emergency.
Yes. Yeah. After the public health emergency, COVID-19 vaccines are in that category of the Part B vaccines that are preventive and that will be available at no cost to the person with Medicare.
Excellent. Tricia, who do we have up next?
We're going to go to Martha's question on YouTube. Her question is, are prescription plans through a retirement pension plan the same as Medicare Part D?
Leigh, can you help with that?
They are considered Medicare Part D plans, yes. And what we are talking about, though, today is more of the, we'll say, traditional Part D plans. So you're talking about your standalone prescription Part D plans and your Medicare Advantage plans that also have Medicare Part D in them.
Okay. Tricia, let's take another question.
Let's go to Jenny in Minnesota.
Hey, Jenny, welcome to our program. Go ahead with your question.
Thank you. Insurance for Part D is not included in the $2,000 out-of-pocket cost for drugs. Our insurance for Part D went up a lot this year. I am wondering, is there any program or anything that's going to cap the insurance costs? Because if the insurance costs keep rising, that $2,000 cap isn't going to help much.
Dr. Seshamani, can you address that for Jenny and others who might have the same question?
Yeah, thank you, Jenny, for that question. So part of the new drug law has a premium stabilization program to limit any changes in premiums over the next several years. And so that will help with some of the premium changes that you're alluding to.
Say a little bit more about that, if you would, Doctor. What do you mean by premium stabilization?
Meaning that premiums will not change significantly. So it's stabilizing premiums for several years, I think maybe 6 years.
Okay. Is it putting a cap on how much they can increase?
It's more depending on where they are. Yes, it's basically, stabilizing the premium amount.
Okay. Great. Thanks for that clarification. Tricia, do you have another question for us?
I think we have one more from social media. If you have supplemental insurance while you are on Medicare, do they decide the price of all the tier and covered expenses?
Leigh, do you want to tackle that one?
So if I'm understanding the question correctly, supplemental is actually operating outside of Medicare Part D. Medicare supplemental plans cannot cover prescription drugs. So what we're talking about today are specific to Medicare Part D plans, whether it's the standalone plans that I mentioned previously, or the Medicare Advantage that also include prescription drug coverage.
Okay, thanks very much to both our experts for that. Dr. Seshamani, we had talked a little bit about caregivers and Medicare. I want to return to that topic. Of course, more than 50 million Americans are family caregivers for a loved one. What changes are taking place in Medicare to help them? And what is your vision for Medicare assisting family caregivers with these really important duties that they have?
Yeah, thank you again, Bill, for bringing up the issue of family caregivers. CMS is definitely embracing more direct support to family caregivers. So some examples. We're developing, localized public messaging and outreach on various family caregiving supports that are available in the Medicare program, such as durable medical equipment, respite care, home care, hospice, things that, are really helpful for caregivers to know as they're caring for their loved ones. And throughout our policies and programs, we are taking steps to recognize caregiving. So, for example, we pay for cognitive assessments in Medicare for people with signs of dementia. And as part of that cognitive assessment, it includes identifying a caregiver, what's their knowledge level, their needs, social supports, what is the willingness of and ability of the caregiver to take on caregiving tasks. So I give that as, one example of where through our various programs and policies, we seek to recognize family caregivers and incorporate them into the plan and delivery of care. Medicare Advantage organizations, at their discretion, may also deliver additional services focused on caregiver support. And then I think, more generally, we really want to engage with the community and hear all of your ideas about how we can support programming to support our caregivers. For example, in our regulation last year, we included a request for information related to a new code for caregiver behavioral management training so that there can be a payment for this kind of training for caregivers. So we want to engage and get ideas on how we can continue to better support caregivers in the Medicare program.
Okay, thanks so much for that. And Leigh, let me ask you about other Medicare priorities that AARP feels needs to be addressed. What's the focus today?
Yeah, I think Megan did a really great job of recapping where AARP is right now, which is to say that we are incredibly focused on ensuring that Medicare is protected from harmful spending cuts and is available as an important benefit for Americans that have contributed to and earned throughout their lives. You also heard kind of our laundry list of issues that we are working on. And so in terms of a short way of saying that, I think it's safe to say that we are very well aware that healthcare costs continue to be a challenge for many older Americans. And AARP is going to continue fighting to ensure that they can access the care that they need. And finally, AARP is incredibly committed to supporting the successful implementation of the law that we have been discussing today that reduces prescription drug prices and costs for older Americans. And that includes fighting any efforts by big drug companies to overturn it.
Okay, well, I'm sure those are coming soon, so we're going to be looking for AARP to be guarding the gate on that. This has been a really informative discussion. I want to thank each of our experts for the time and expertise today, and thank you, our AARP members, volunteers, and listeners for participating in this discussion. AARP, a nonprofit, nonpartisan organization with a membership, has been working to promote the health and well-being of older Americans for more than 60 years. Few issues have been more important to AARP than protecting and improving Medicare. And if you're looking for individual assistance with Medicare, visit shiphelp.org or call toll-free 877-839-2675. When prompted, simply say Medicare to be connected with a Medicare counselor in your state. That toll-free number again is 877-839-2675. All of the resources referenced in today's program, including a recording of this Q&A event, can be found at aarp.org/RX beginning tomorrow, February 10th. Go there if your question was not addressed, and you'll find the latest updates as well as information created specifically for older adults and family caregivers. We hope you learned something that can help keep you and your loved ones healthy. Please join us on February 16th at 1 p.m. for a teletown hall focusing on the coronavirus and vaccines. We hope you can join us at that time. Thank you and have a good day. This concludes our call.